So colleagues, good morning or good afternoon, depending on where you are in the world. Welcome to the Usher COVID-19 webinar series from the University of Edinburgh. My name is Linda Ball. I'm a professor of public health in the Usher Institute. And we are today going to be focusing on the experience of Australia. And before I hand over to the speakers and introduce them, I'll just take you through how we run the webinars. I know many of you have registered and joined us in the past. So we won't be able to see you. And we also can't hear you in terms of the audience. But if you do have a question as we go through the webinar, please do post that in the Q&A box, which you'll see at the bottom of your screen, not the chat box, but the Q&A box. Please do put your questions there. And then when we get to the end of the webinar, I'll be able to ask the speakers those questions. I'm sure some really interesting questions will come up. And then at the end of the webinar, I will introduce the next two sessions that we now have scheduled. So I'm really pleased that we've got two very experienced colleagues right in the thick of it in Australia in terms of what has been the case or what people have been experiencing there in recent months. So I'll just say something about them both briefly. So our first speaker is Dr. James Wood, who's an associate professor in the School of Public Health and Community Medicine at University of New South Wales, Sydney. And he's an infectious disease modeller with a background in mathematical physics, and he works on the analysis of interventions for pandemic responses, vaccine preventable diseases, and also sexually transmitted infections. So he did a postdoc at the National Centre for Immunisation Research and Surveillance, and then he joined UNSW Sydney in 2008. So he's very experienced. He's been heavily involved in the Australian pandemic planning in the past, and also modeled previously vaccine rollout. So he's now involved in the coronavirus modelling in terms of the responses as part of a national team, and he provides forecasting reports for governments and the Ministry of Health, and he's also importantly supporting responses in Philippines and Malaysia. And our second speaker, Dr. Michael Lydeamore, is from the Department of Health and Human Services, Victoria, and also Monash University. So he's got this joint appointment at the moment between Health and Human Services and the university. He's also an infectious disease modeler, and he completed his PhD in the control of skin infections. He joined Monash in 2019 and also joined the Victorian Department of Health and Human Services specifically as part of the COVID response earlier this year. So he's currently the modeling and forecasting lead at the Victorian Department of Health and Human Services in the COVID-19 division. So he's responsible for the dynamic modelling and advanced analytics of the department's data related to COVID. So you'll see some hugely relevant insights there. So I'll hand over to James, and he's going to speak first, and then he'll hand over to Michael, and we'll have questions at the end. So we'll just give James a second to bring his video up and also to start screen sharing. Great, thank you very much. Over to you.
Hi everyone. Very nice to be here. And if I can just give me one tick while I try to figure out how to. Here we go. Okay. Hi everyone. It's great to be here tonight. Linda's given me a great introduction, so I won't dwell on that. But I'll just say I'm giving this talk from Bidjigal land here in Sydney today, and I'd like to pay my respects to elders past, present and emerging, as we customarily do in Australia. And I'm going to sort of cover the first half of this talk and try to talk about Australia's experience sort of generally and sort of at a national level in terms of modelling work for COVID-19. And then about halfway through, I'm going to hand over to Michael to talk through the Victorian experience in more detail, and particularly the second wave that they've been encountered recently. So Linda said quite a bit about my sort of personal trajectory here. I don't need to dwell on this too much, but I guess when I arrived in modelling infectious diseases was just when H5N1 was a major concern in Southeast Asia. And it was a time at which a lot of countries around the world invested in pandemic planning, because there was a limited amount of evidence available from past pandemics. They looked to modelling in terms of how to consider what the effective strategies would be. And so I was an author on this report, published in 2006, that's at the right of your screen, led by Niels Becker, who's now retired, which set kind of the foundations for modelling being a key component of pandemic planning in Australia. And I sort of participated in things like writing simulation exercises as well in that period, and later contributed in swine flu. I'm just going to kind of move on because we're conscious of time. And so just a bit of an orientation to Australia. I know many of you listening might know it well, but I tried to kind of put together a quick demographic sort of snapshot. And so Australia's a high-income country with a median age of 37. It's got high life expectancy and a pretty significant population over 65, which of course is relevant for COVID-19. Its climatic zones range from tropical to temperate. And if you think about Melbourne, it's our southernmost large city, but its latitude is actually similar to Lisbon or San Francisco if you flip to the northern hemisphere. So it's not that far south if you think about it. So if climate's a factor with COVID, maybe we don't suffer as much as Northern Europe. It's a mostly urban population, so more than 85% of our people live in urban regions. Overall population's about 25 million. But for those who've been here, well, you kind of know that our urban is low density compared to Europe or Asia. And I guess another big feature of Australia is that we have a large Indigenous population. The census in 2016 was about 800,000 people in Australia. And I guess just to kind of highlight where those people live, there is a significant population in the Northern Territory, sort of a northern central part of Australia, but actually most Indigenous people live in regional and urban areas on the east coast of Australia. I just wanted to kind of paint a picture of where we are at the moment, and I'm using mobility data from Google to sort of do this. And we're in very different states in our different parts of the country. So if you look at the Northern Territory, essentially we're back to baseline behaviour there. In fact, baseline was in summer in Australia, so you actually see more people at work now than you did in sort of January and February. Okay, so going to their workplaces. But if you look at New South Wales, where I'm based, where we do have clusters of cases, we still have a lot of people working from home, so to speak. So you're kind of down 20% on typical activity. And if you go to Victoria, you can see the effects of the lockdown. So they're sort of at more like minus 60% in terms of people attending. So this is the same country, but how did we get to this point where we're in such different states of COVID response? So I've got a really busy picture here, but I'm trying to paint an overall picture. So we got our first cases in Australia in late January. And I guess a series of things happened after that, which I'll get to later, but the cases numbers started to tick up at the beginning of March, and were primarily driven initially by lots of overseas importations, particularly from the UK and the US, which at that stage weren't aware that they had large epidemics brewing. And this led to subsequently, a week or two later, growing case numbers in locals. And two kind of significant things happened at that point. We greatly restricted movement of people into the country from overseas. So essentially you couldn't leave or very few people could come in. And a week or two after that, we required everyone to go into hotel quarantine. Okay. And then locally, we were introducing a number of significant social distancing restrictions, which did not go quite as far as what was seen in Northern Europe. But for example, that public gatherings were limited to 2 persons. Most people were working from home. Restaurants and cafes and so on were all closed. And the combination of these two measures was successful in greatly bringing down COVID cases, so that we had fairly low numbers into May and the early part of June. And then towards the end of June, Victoria started to see a second wave, which was emerging quite rapidly. I'll let Michael talk more about that. But since that point, we've ended up with most states having border closures between each other, so that at the moment, I can barely go anywhere in the country because we've got hard border closures for most of the country with New South Wales. So that's kind of why we have such different states. We're almost like different countries in the same country at the moment. And to move on to sort of like the epidemiology, just a kind of a quick descriptive snapshot in Australia. Our age distribution is pretty similar to anywhere which is doing of cases is pretty similar to anywhere which is doing a lot of testing. So we get a peak in the sort of the 20 to 29 year group. Lower case numbers in school age and younger kids, despite plenty of testing. And then you sort of see in older people, and this is case numbers here, in older people that probably a slight rise in incidence in older age, but it tends to follow the sort of the trajectory of our age-specific populations, so to speak. You can see we've got massive differences between states, in terms of the size of the epidemic. So that Victoria has had a huge amount of local cases, but most other states have largely had imported cases and little local transmission. Another kind of key feature, I guess, and not one which is surprising for people in other countries, is that we've had problems with residential aged care in terms of having really significant deaths in that population. So we've had just under 800 deaths in Australia thus far. Nearly 600 of those have been in residential aged care. And if you compare that population with the rest of the country, the fatal fraction in residential aged care is about 30% currently, and will probably rise because there's still a number of active cases. And the fatal fraction outside of aged care is 0.8%. So it's a huge difference in terms of risk, which obviously is mediated by age and also frailty. So Australia's seen internationally, I think, as having done reasonably well, but within our region, the Western Pacific region of WHO, our sort of performance is par for the course, or even perhaps below average. So I've just pulled the kind of latest statistics from the WHO here for our region. And while the Philippines has a sort of a large epidemic, on a per person basis, pretty much everywhere else in the Western Pacific region has had a lower death toll per million population than Australia. So we certainly look good compared to the United States and a lot of Europe, but not necessarily in our part of the world. So I'm a modeler, and I want to talk a little bit about how this has contributed to responses. I mean, I think it's important to say with responses to COVID-19, you don't need modeling necessarily to know what to do. I mean, if you are prepared to act quickly, that's probably the best thing to do. And then modeling can help in terms of sorting out sort of strategic measures in the longer term. But where we came into this, and I think this is fairly similar to most pandemic plans internationally, was that we had not too much of a focus on border measures, sort of limited border measures, more kind of for awareness and testing of travelers. Case-based isolation and quarantine. We used reactive school closures from the beginning, so we were pretty prepared to do things like that. And potentially we would use wider school closures and work from home sort of policies. That's kind of where we came into this thinking what we would do. And obviously we've seen vast changes in that. So currently hard border closure, both for international and domestic travel, 14-day hotel quarantine for both those settings as well, in many cases. A high testing rate, so about in sort of New South Wales and Victoria, about 2.5% of the population is tested every week. And our sort of outbreak capacity, including contact tracing, has been scaled up pretty dramatically. So New South Wales Health, I think, has scaled up their contact tracing group by about a factor of 60. And similar things have happened in Victoria. And we've got massive variation in regional restrictions because of, for example, these border closures between states, which allow states without cases to get on with life pretty much as normal, and states with cases to be under some measure of restriction. So I just want to talk a little bit about how our sort of early actions and how this related to work from modelling. And I think two critical things that happened early on internationally were sort of release of evidence from Imperial College and from the sort of the papers that came out of people from Hong Kong doing work with sort of Chinese data. And essentially the combination of these two things led to border closure with China being enforced in Australia in the start of February. And this is a pretty major decision because Australia has a lot of travel and trade, etc., with China. Our universities are very reliant on Chinese students, and it wasn't a decision to be taken lightly. So, that was the first sign that we were prepared to strongly deviate from our existing plans. And then following this, I guess immediate sort of consequences are, well, it might not spread to us directly from China, but it could come from an intermediary country. So risk assessments for entry of infection from the region were begun, and local models of the potential epidemics and the impact on intensive care and hospital demand started. And all of this sort of started happening from about the middle of January on, the beginning of the process. I didn't really get involved until the second week of February, when I kind of asked James Zakor and Jodie McFernan, who were sort of leading the national effort, whether they'd kind of like some help, and they said yes. So I started to get involved then, and I've been in sort of meetings several times a week since then, doing plenty of stuff. So specific modelling efforts since then, I guess, have been around things like forecasting, looking at capacity for testing, and which is now shifting to more detailed analysis of clusters and things like reporting indicators. A focus on specific populations, so how to help sort of remote Indigenous communities have policies to keep them safe, and kind of utility of some of the things we're working on at the moment, I guess, things like what's the utility of spatial and mobility data, and we're trying to get as much as we can out of data from household clusters. So just to kind of visualize what these sort of early sort of inputs is, this is the kind of the paper by Joseph Wu et al. In the Lancet, which sort of pointed out these sort of risks of export of cases from China to different parts of the world. And at the right on here, I've just kind of given an indications of sort of what this sort of risk matrix looked like from regional centres in the period before we realised that we had multiple large epidemics in different parts of the world. And in terms of severity projections, kind of these sorts of scenarios that we were generating about the demand for ICU, with just what we were planning on doing already, or with adding things like social distancing. And maybe it's just an indicator of the sort of things that we used to, I think, help convince government that we needed to do more than just our existing plans, were these sorts of graphs of how ICU capacity simply would not cope with admissions, even if we could scale up our sort of size of ICU, the number of ICU beds, or acquire more ventilators, that we would not be able to cope with demand unless we kept infections low. And I should note that this is all going back really to March, before we started to realise that you really don't want sizable fractions of people ending up in ICU at all, because a lot of them die in that context. And so that sort of information was coming through and sort of starting to adjust how we would deal with things. So a kind of a quick summary of the first wave. Just, and sort of I'm thinking about March to April here. I guess we became aware of other national epidemics and expanded border restrictions. Once we realised we were getting cases coming in from places that didn't realise they had large epidemics, Australia decided to close borders to non-residents, and they instituted a 2-week self-quarantine. But then there was growth in local cases, and this led to some kind of version of lockdowns being applied nationally from sort of mid to late March. And by the end of March, we'd decided on requiring our much reduced rate of travellers to be in hotels for 14-day quarantine. Okay, so the combination of these things, lockdowns restricted local transmission, and the travel bans combined with hotel quarantine effectively shut down the importation risk, at least in this period when we had lockdowns in place. So post wave one, there's a number of challenges. I haven't got a great deal of time to go into detail about this, but just to say that, forecasting with COVID is difficult. Probably this has been said in these seminars before, because everyone's trying to keep the reproduction number down to around about 1. But a small divergence in this up or down can lead to huge changes in your trajectories. And one of the additional dangers or difficulties we've had is I mean, we've got few cases, which is good, but when you have few cases, you don't have much information to estimate this. And that makes both estimations of that and projections quite unreliable. So we've tried to address that, and so this is work that Nick Golding and Freya Shearer and David Price in particular have been heavily involved in terms of collecting the data and developing relevant models. And this has been used of surveys and kind of macro mobility data, such as Google mobility data, in order to try to do inference. And I've sort of provided a kind of a schematic of how you take these kind of indicators developed by surveys, you combine them with sort of case information, and you develop some kind of ability to estimate the reproduction number over time. But in practice, except when you've got lots of cases, such as in Victoria, you end up with wide uncertainty intervals on this. So it still makes forecasting difficult. And I've kind of put examples in here of what sort of ranges you get for this. And of course, you don't have to go very far out into the future to get wide divergence. And this is Victoria, this is New South Wales. I should say in New South Wales, because these models didn't take into account importation risk from Victoria, they ended up underestimating what was going to happen in early July in New South Wales. So that's my quick sort of run through the first part of the epidemic. Kind of a few just very quick points I want to make before I switch over to Michael. So firstly, that this is evidence from sort of genomics and phylogenomics applied to genomics in terms of estimating reproduction numbers. There's a sense that when COVID first arrived, that it wasn't spreading as quickly as it did in Northern Europe. So maybe climatic factors are sort of some importance. We found in New South Wales that for the last 2 months, a cluster control just by tracing and so on has been successful in keeping case numbers low. So it sort of suggests that this works a bit better than models expect, perhaps due to the kind of the nature of COVID and being something of a clustered infection in terms of how transmission works. Divided responsibility leads to problems. So I've just highlighted a couple of early things we had. So we have situations where state and federal authorities both manage situations, and that kind of dual role has led to problems. So it's led to problems around border control, for example, with the cruise ships early on in terms of letting people off when perhaps they shouldn't or should have been tested. And in terms of aged care, where we have federal responsibility for managing, but sort of state health departments are supposed to deal with outbreaks. And in both of these situations, we seem to have, in some sense, had a bit of a lack of leadership around how we deal with these. And I guess one of the things is there was never quite a consistent national plan in terms of how we what the end game for COVID was. So a number of the states pursued essentially an elimination policy, and some didn't. And the national policy was around suppression. And so we've ended up in this situation where a number of states and territories have achieved elimination and others haven't. And this has led to these sort of border controls and sort of people getting charged for going across borders, whether or not they pose a risk, and sort of a bit of a divided country. I should quickly note that hotel quarantine we've found fails occasionally, and there was a lot of kerfuffle about this in Victoria. But since that has happened, and that was linked to almost all the cases in the second wave, but since then, New South Wales has shown they've had unlinked transmission to security guards at hotels. New Zealand has had at least one case of transmission. So it does fail periodically, and the risk is probably something in the order of 1 in hundreds of cases, but you get plenty of cases coming in, you'll get failures in hotel quarantine. A couple of very quick points. We've had no flu at all in winter, and we look like we won't get any excess mortality in winter, at least in other than Victoria. And some areas that we're turning towards, I guess, are still trying to, optimize approaches around clusters to see whether this can lead to less restrictions in other ways. And I guess we're moving to preparing for vaccines too. So contracts have been signed for 2 candidate vaccines. We don't know if they're going to work, but looking at how they will be applied and whether for disease or transmission prevention is going to be something we're going to be considering. So I'm going to stop there and then pass over to Michael. I think.
Thank you very much, James. That was excellent. And I've written down some of my own questions. And I see the questions are starting to come through. So that's brilliant. So hand over to Michael now, and thanks again.
Yes, hello everyone, and thank you for tuning in to hear about the response to COVID in Australia. My role as the modelling and forecasting lead in the COVID-19 division in the Department of Health is really to construct and translate modelling both for policy relevant advice and also for the purposes of investigating whether or not what we're doing is working. Linda gave me a very good introduction back at the start of the talk, but a brief personal roadmap for me. I am, by all intents and purposes, a junior academic who's ended up in this position. I joined Monash University pretty much straight out of my PhD in 2019, and that came with an honorary placement of the department. And because I'm an infectious diseases modeler, I was recruited fairly early on into the COVID-19 response in late February or early March. I don't remember exactly, for the purposes of understanding the modelling that James was just talking about that was being given to the Commonwealth and then fed down to the state jurisdictions. And I was appointed the modelling and forecasting lead for COVID-19 in late March. So Victoria's experience has been a bit different to the other states, as James highlighted. We had a first wave, as did pretty much all of the country. We had this period of constrained transmission after the initial wave appeared to have disappeared. And then we had this fairly sizable second wave, although compared to international experiences, perhaps not as big as one would expect. And we have since actually shown really good signs of control of this wave. But it does highlight that Victoria and many other states still remain at risk to COVID. I won't spend a lot of time about the restrictions that have gone in and out of Victoria. I think James covered these quite well, but just to give a little bit of background on the language, like a lot of countries, we had a 3-stage process for turning on restrictions, which gradually decreased the ability of people to move and gather. In May, we then had 2 of these released. The stage 1 release is the stage 3 to stage 2 transition, and the stage 2 release is effectively stage 2 plus a little bit more. And in early July, we had localized lockdowns reinforced. And then by the 9th of July, all of metropolitan Melbourne was back in stage 3 restrictions. And on the 2nd of August, stage 4 restrictions came in, which is the tightest restrictions across Australia. That involves a curfew from 8 p.m. to 5 a.m., only one person being allowed out of a household at a time, and very strict and limited exercise times, and a handful of other things that go with that. And today, Victoria is still in stage 4 restrictions. So as James mentioned, the first wave across the country, and Victoria was no exception, was primarily driven by overseas importation here in this blue color. And this was followed by small but relatively controlled chains of transmission in relatively small populations where the virus didn't spread. We had this period of small localized outbreaks. Just note a change of scale here on the y-axis. So we had no more than 30 cases per day between May and June. And I've just highlighted here the points of where we eased restrictions. And during this time, we were still getting a handful of overseas importations. And just at the end of this plot was the signs of danger. And then another y-axis change, and we had this big second wave, which was almost entirely locally acquired cases. There are just a handful of little blue specks down here that were some overseas importations, but for the longest time, Victoria has not had an overseas acquired case. And so just to note here that we went from not having 30 cases per day throughout May and June to having over 600 cases per day in August. So just further highlighting what everyone on this call I'm sure knows, which is that COVID can spread very rapidly through a population. So modeling in the department is slightly different to my academic background, and there's almost 2 distinct streams. There's modeling for monitoring, which is how do we know when there's a problem and are we doing enough, or could we do more in terms of the easing of restrictions? And then there's modeling for evidence, which says, are we making the right choices and what do we need to invest in as we move forward? I'll talk about each of these in a bit more detail. So modeling for monitoring, and this is one of the things that I've had to learn very rapidly, is that operational needs change all the time in COVID. And this could be related to hospital capacity, thinking of the ICU projections that James was showing before. Do we turn on and off elective surgery? Where do we turn on and off elective surgery? and what happens when a nurse or a doctor tests positive for COVID and we have to take out a chunk of our workforce. This has been a big issue in aged care, and modelling has contributed there to help us understand how many staff we need, how many we're going to be missing, and what do we need to change, often on a very short timeline. The other part of modelling for monitoring is what would often be classed as surveillance. So this is looking at some key numbers that can indicate trouble or success. So the R effective, which is the average number of cases infected by a single confirmed case, is one of the most looked at numbers, although is not without limitation. We also look at things like the geographic distribution of cases. Is it moving across the state? And what does that mean for where we need to target testing or community engagement? And we also look at quantification of areas at risk. So if virus was to get to a certain section, say like public housing or aged care, how big of a deal will that be and how should we best respond? So a case forecast is one thing, and James gave a good overview of the forecasts that are going on, but in Victoria, health services are not centrally managed. And in fact, they're separated out into over 100 different organizations. And for the purposes of COVID, they have been grouped together into 9 clusters. And so we need to forecast for each cluster. There's no point a health service over in the east doubling its ICU capacity if all of the COVID cases are over in the west, and where they're not going to be able to travel across to the east very easily. So this is an example of what I would call operational forecasting. Okay, great. The state's going to have 300 cases per day for the next week. Where are they going to be so that we can make sure that we're making the right changes to the system where they need to be done? Another good example here is the changing geographic distribution of cases. So early on, we saw overseas that if a virus makes its way to areas of socioeconomic disadvantage, it's far harder to control and keep on top of what's going on. And this analysis was done in that quiet period before the second wave, and that highlighted to us that it had moved. Our first wave was largely in wealthy communities, where for whatever reason, the chains of transmission were not continuing. But during that March to May period before the second wave, we'd started to see that demographic move over to areas of more disadvantage, which means that we need to be engaging with those communities and doing more to make sure that we stay on top, because the likelihood of spread in those areas is so much higher. A great example of operational modeling was this fairly ugly looking map. And so we had undertaken some analysis that said if people live more than 5 kilometers from a testing center, they're far less likely to be tested. Now, flip that around and we can find areas where people live more than 5 kilometers away from a testing center, which are highlighted here in orange. And when we produced this map, I'm very proud to say that within a week, these holes were plugged with testing centers. And that, for me, was a great example of how quickly we can respond, but also the power that modeling can have in terms of guiding that response. So the effective transmission number, no COVID modeling talk is complete without showing it off. So we estimate this using a statistical framework that is almost mechanism free in a way. And a big assumption here is that we assume that active cases are representing our average behavior. Now, that's not going to be true in an aged care setting or in, say, crowded housing if the virus isn't always there. And so spread in subpopulations can be different to what is indicated on the R effective. But nonetheless, it forms one of a suite of numbers that we look at very closely when we're deciding in terms of our operational response and what should change and when. So in wave 1, as James was saying, the R effective was very low, bottoming out 0.5, 0.4-ish. We had a spike related to local transmission, but we kept it generally under 1 with that constrained transmission, followed by the surge in wave 2, followed by the decline that we've seen today. So I'll move now to modeling as evidence, and modeling as evidence for the department is really undertaken to drive investment into key areas, and I've got a couple of examples of that, and also probably more topically to understand the necessity of restrictions in Victoria and also quantify if those restrictions are appropriate. And on the flip side of that, assess risks with easing of restrictions. What can we ease and when? So I've got 2 models that I'll just talk about briefly. The first one of these is the compartmental model, very similar to the model that James described that was provided to the Commonwealth. And so this was developed in February through to April a compartmental SEEIIR model. And this, at the time, was based largely on international knowledge. We didn't have a lot of cases in Australia to parameterize to a local context, but it was consistent with what we had seen, as limited as that might have been. And this was used within the state government, to justify our public health action, so our first set of lockdowns, and also drive our investments into the health sector to prepare for a worst case scenario. So this is an example curve here for daily incidents, and we're talking many tens of thousands of infections per day. Not all of these will be detected. Not all would be severe cases that would pose an impact on our health system. But nonetheless, that's a big number. And at the time when we were looking at these, we were having handfuls of cases per day, so certainly less than 100. Translating that into an occupancy issue, we're talking 10,000 intensive care beds. That's almost 2 orders of magnitude higher than the intensive care beds available in Victoria, and 7,000 of those would need ventilators. And when we became aware of this, Victoria invested very, very heavily into ventilators and training of staff and retraining of staff as a just-in-case measure for this type of outbreak. Now, thankfully in Victoria, this didn't eventuate, but the modelling did help us prepare for if it did. More recently published out in the media is the stochastic agent-based model. Now, this was developed by a team from the University of Melbourne in collaboration with the Department of Health. And this model was based almost entirely on local observations. Unfortunately, being an agent-based model, being the behemoth that they tend to be, we can't fully calibrate absolutely everything to all of the information that we have, although the summary statistics that we've looked at do look sensible for our local experience. And this model was used to explore what we'll term endgame scenarios. So when can we start to ease restrictions safely without risking having to yo-yo back in to another set of lockdowns? So just a couple of results slides from this one. So if Victoria was to open at 25 cases per day over 2 weeks, the red line here is indicating that we would need another round of lockdowns, and the green lines are indicating that we're still in the level of easing that we would be happy with. And this paints a relatively grim picture by the end of the year, which is that grey dashed line that's a little bit hard to see on this plot. It's almost a coin flip as to whether or not we would be in a lockdown again or not. Comparatively, at a 5-case opening threshold, so that would be 42 cases over the 2 weeks, it's much, much more likely, although not guaranteed, that Victoria would not require another set of extensive lockdowns. Now, as James said, forecasting or predicting this far out into the future with any model will have a lot of uncertainty, and you can see here on this plot, some of these runs have gone way off, up into the hundreds of cases per day. But as part of the operational response, we need to try and quantify that uncertainty to pass on to our decision makers. So modeling in the department has been a bit different to me compared to modeling in an academic environment. And I like to say that it walks the line between two things. You know, we've driven key parts of Victoria's response, and we as a modeling team and as a team inside the department will continue to do that. It is only one piece of evidence that is used in decision making, as it should be, and observations of reality will always take precedence over the model predictions. You know, if the model says stage 3 restrictions should have cases going down, but they're going up, well, it would be a bit silly to ignore that and say, well, the model says it should go down. Communication of modeling results to policymakers is an ever ongoing challenge for me. You know, models are a quantitative tool in the sense that you get a number out. We know precisely what the percentage is according to the model, but really it's the qualitative insights that are of most value when you're designing a policy. And to communicate that across is a big part of my role. And I think the Victorian government has done a pretty good job of understanding that and taking that on board. And we are always striking a balance between investigation, you know, what can we see when we look in our data, what trends do we not know about, and also policy-driven work. Okay, next week we're going to open up all the swimming pools. What's that likely to actually do to our risk of spread of COVID? And I think the key point for me working in the department as opposed to working in a university is saying, rather than saying, what are my findings, we always are asking, how does this change what the response in Victoria is doing? So it's been a great experience so far, and I think Victoria has done pretty well with the cards that it's been dealt, and modelling, I think, has made a very good contribution across there. That's all I have to say. So thank you.
Great, thank you very much, Michael. That was excellent. I'm just going to move the Q&A box. We've got some great questions here. I think I'll just start actually with one of my own questions to you, Michael. Given the, the impressive work that you've done, but also the opportunity of being in that role at your stage in career, what have you learned around the point you just made around the communication modeling results to policymakers? What have you learned as the weeks have gone on? You talked about quantitative versus qualitative insights, but how has your own approach improved and that of other members of your team, and how you kind of try to communicate the risks and benefits to policy colleagues who, quite frankly, will be looking at your data and not really fully understanding what it means?
Yeah, for sure. I was very fortunate, actually, in my PhD, which was under James McCaw and Jodie McVernon, to be given a lot of training in that translational part. And I think at the time I perhaps didn't appreciate how important that was. But it is an ongoing, evolving thing. I remember when that first set of modeling came out, sitting around a table and saying, a very senior person saying to me, "Oh, but we're 7 beds short." I said, "Well, hang on, what do you mean we're 7 beds short?" And they're like, "Well, you said we need," I can't remember what the number was, but it was very slightly more than what we had. It is an ongoing training in both directions. I've learned a lot about what you should withhold in inverted commas. And also, I think the policymakers and the decision makers have also learned to take the right messages out of the model as we've gone on.
And do you think that combination of what you called your CR2R, probably mispronouncing it, model, and the agent-based modeling, those two in combination have been particularly valuable?
Yeah, I think it's always important to look at whatever models you have available, however many you have. I think thinking about this roadmap, all the modeling that is around, including stuff from outside the department, would tell you the same story. The less cases you have, the better. And we certainly try to use them almost like spanners in a toolkit. The more spanners you've got, the more likely you are to be able to tighten up whatever bolt comes your way.
Great. Okay, I'll move on to my other questions here. So we've got a couple of points here just on the testing. So how is the testing organized in Victoria? James, you might want to comment on this from the perspective of New South Wales as well, such that you were able to plug the gaps. So again, you gave a really good example there of the geographical spread of the testing centres. So I guess a couple of questions emerged from that. On what basis did you decide that people wouldn't travel more than 5 kilometres? And how did you so how did you plug the gaps? And then the second part of that from Lawrence Greer is, do testing systems vary from state to state? So maybe if you could answer first, Michael, and then we can hand over to James on the broader point.
Sure. I think, yes, testing differs state to state would be the easy answer to that question. In terms of how we worked out where people go, and when you're tested in Victoria, and I think nationally, they take your address and we geocode that as part of our normal communicable diseases practice that would go on outside of COVID as well. So that means that we're able to look at a map of where people are and also where the testing centres are. We just look then at the population density and we get an idea of who isn't being tested. We don't know it's because they lived far away from the testing centre. That's an inference that we made.
Right.
But it seemed consistent with what was going on at the time.
Okay. James?
Yeah, it's I don't know. I mean, it does differ nationally. I mean, what seems to be the case is we seem to have been able to do about the same amount of testing right across the country. I think New South Wales was maybe able to scale it up more quickly at the beginning, and it depends a bit. Some of our sort of systems are more regionalised and some are more centralised, and that's made a bit of a difference. But we don't seem to be in a situation where we've been testing kind of poor since at the end of March, really.
And were there any targets set for testing? That's a question from Richard Simpson.
This is at times a bit of a controversial issue. So there has been, politically, it's been attractive to announce large numbers of tests. And at times there's a wonder if that leads to delays in communication of results that might actually be slightly disadvantaged. But at the moment, say in New South Wales, we're doing so 2.5% of the population a week about is being tested, and it takes about a day to get notified. So from your test, so it's pretty quick. So we seem to have the capacity to do that without it interrupting what's going on.
Great. Okay. So just moving on to more broader points here. Actually, we'll just stick with testing for a couple more because I see there's a few. Whoever wants to answer this. Do university children and university students and children, are they eligible for testing? And also, are you looking at what we're having this big debate here about saliva tests, some of the rapid tests, group testing, you know, you would test 20 samples at the same time. So just tell us a little bit about how that landscape's evolving.
So I might go, I think Michael might be able to talk a little bit more about things like saliva testing and so on, because I think they've done that in Victoria. But so we definitely do pooling because we have very low prevalence. I'm not sure whether it's probably something like 10 samples per test that's sort of standard practice here. I don't believe we're using rapid tests at the moment. Saliva tests, I don't think they've been widely used outside of Victoria, and Michael might be able to comment on how widely they've been used there. I don't think we were happy with the performance of them in terms of but there's sort of this argument that you don't necessarily need really high sensitivity for certain kinds of uses, and so that may still come back in as a question here. In terms of, I guess, universities, I mean, we basically haven't sent universities back in places where we've had significant cases as yet. So our students will be coming back next week, actually. We've been doing everything online. In Victoria, they're not running unis at the moment. Say Queensland's back, but they've had almost no cases, and same in WA and South Australia. So we haven't really had that experience. But we've had schools back here for quite a long period of time, and I guess there's pretty strict rules about getting tested if you have any kind of infection before you come back to school and being proven to be COVID negative. And we do get school closures, I guess, but they're usually for a day, and we're not seeing a lot of school-based spread. And I think the statistics here are not very different to what's been seen in the UK and, say, the Netherlands, where it's often brought in by teachers.
Anything to add, Michael?
Yeah, so saliva was used as part of a mass testing blitz during that quiet period in Victoria, but as far as I'm aware, it's not being used routinely since. I actually don't know exactly why that is. I suspect for the reasons that James was talking about before, sensitivity and specificity. We don't actually quite know the sensitivity and specificity of the PCR test even. So it is an ongoing issue, testing, and how much should you test, as James was talking about, but we do test a lot.
And question here from Nigel Applewhite. How quickly after cases were identified in Victoria or indeed elsewhere did hospital admissions increase? And given that clearly the priority now is to protect your aged care, I would imagine that your modelling is really being informed by the fact that you're going to try and essentially remove that population from being at risk by repeat testing of staff, for example. So two parts to that question. Yeah,
it's a good question. So going off the top of my head, I think it's about a 5 or 6 day delay from cases, notifications going up to hospitalizations increasing. The exception to that, strangely, is aged care. And that is because aged care facilities in Victoria, a lot of them that were at risk or had COVID were decanted into hospitals. So those patients are already in hospital, COVID negative, and or potentially just exposed but not yet testing positive and tested positive later. In terms of especially mortality, which is very age dependent, as James highlighted, yes, we do a lot of focus on that. In fact, we use a model that's explicitly age-based for that purpose. And in terms of risk of aged care facility, it's an ongoing beast of work to work out why it's getting in, and particularly once it's in there, which we sort of resign ourselves to in some way, why does it get out of control or not? And then just a question around the types of populations you have in Australia in both New South Wales and Victoria. So obviously globally, you'll be aware that there's higher numbers of cases in disadvantaged communities. So maybe you could speak to that. And also your Aboriginal populations, how have you worked to protect them? So I guess that's probably a question for either James or Michael or both of you. So I can take the disadvantaged population part, and then maybe James, I'll hand over to you for the Aboriginal part of that. So yes, we do see more virus currently in areas of more socioeconomic disadvantage. Why that is, not 100% sure, as I suspect most people aren't globally. The usual communicable diseases suspects are probably your answers. It's more people living together, not necessarily as greater access to government services and different leave entitlements at work. These are all things that everyone globally is trying to battle with, and Victoria is no exception there. In terms of, and we have a community engagement branch in the government that is tasked with engaging more in those communities to try and get hold of things a little bit more strongly. In terms of Aboriginal communities, the rural Aboriginal communities, James, you might know more than me there.
So yeah, I can comment a little bit. So there's been a big focus on, and very much driven actually by Aboriginal communities here in terms of trying to make sure that they're protected from the risks of COVID-19, because during swine flu, they were at significantly higher risk of severe disease. Part of the reason for this is there's high rates of, for example, diabetes and other kinds of conditions that are exacerbated by these sort of infections. So David Regan, who's a colleague of mine at the Kirby Institute, and others have been heavily involved in sort of modelling, basically commissioned by sort of Aboriginal reference group nationally, who they met with weekly, and basically had a lot of input to this. So essentially, we haven't had cases in remote Aboriginal communities, and in New South Wales, for example, they report by Aboriginal status, and we're not seeing big differences between non-Aboriginal and Aboriginal people in New South Wales. I'm not as aware elsewhere, but since we've had the most cases outside of Victoria and the largest other Aboriginal population, I think we're fairly representative of what's going on there.
And then a two-part question about contact tracing. So we've just introduced an app here in Scotland, just launched last week. So I'd like to hear from either of you on whether that's happening and also how it affects your modelling. And then how does contact tracing and the success of that, from what you know about in practice, affect the models and the approaches that you take?
Okay, so that's an interesting one. I might let Michael talk about. Well, I'm gonna take a little bit on that first, and I think might let him get to the sort of how it interacts with models. But we do have an app. It's called COVID Safe. It's based on a Singapore app. It's not based on the Google and Apple sort of technology. About 40% of people, maybe a little bit adults, maybe a little bit less, downloaded it. I'm not sure how many people have it active on their phone at any one time. It is used, but it's kind of used, I think, more as a cross-check of contact. But maybe Mike can talk a little bit more about that. But our impression is it's sort of a device to help health departments, and it's not led to a huge number of extra contacts and cases being detected, but it's still in use.
Thank you. Michael?
Yeah, I think that's probably a good summary. In terms of how can it interact with our models, the app is bound by a lot of privacy laws, a lot stricter than even collecting the identifiable health data. So it's actually extremely hard to do the analysis on the data to know how it impacts the models. But we do identify contacts. I don't have the number to hand. We have identified contacts that we wouldn't have otherwise identified without the app. But yes, as James said, it's largely a public health tool and an assistance for the contact tracers rather than a control tool on its own.
Great. Okay, and then we've got a two-part question from Lucy Westerman, who's also touching on something I want to ask. Let's maybe start with you, James, on this. So Australia has a relatively high prevalence of obesity and other chronic eye diseases in the population. Is there evidence that populations living with these conditions have been more vulnerable, particularly for severe cases? That's obviously what's happened here in the UK. But also Lucy asked a question about vaccines, and I know you've been heavily involved in vaccine modelling in the past. So what's the strategy for prioritising that? You said there were two, just in terms of, so presumably you're doing modelling around how you might prioritise particular groups when vaccines are available.
So we don't have as yet great reporting on risk factor data. I think maybe Michael sort of more aware of this. I suspect after the Victorian epidemic, we'll have a much better sense of what's been the key risk factors here. I don't think it'll differ much nationally, but I don't think we can say it yet, because until kind of a few weeks ago, we only had sort of 100 deaths in Australia nationwide. So on the vaccine front, I actually haven't started doing any modelling on vaccines, but I mean, it's something I'm familiar with from the past. Look, I suspect it's going to be protection of the most exposed and the most at risk. But I guess the concern is that often with vaccines that your responses decline in the people who might need them most. And then there might be this other approach around trying to target transmission as opposed to disease. And that would be then giving it to sort of healthy people. But you would need large quantities to do that.
Okay, great. And then a question about your advice for us. So we started to see a rise in cases here. We managed to suppress the virus, particularly in Scotland, to very low levels. But cases are doubling now over the last little while. So we really don't want to go back into the hard lockdown we had a few months ago. So just based on the experience of this second wave, I mean, what recommendations broadly, I know we're straying into policy territory, I know you're modelers, but from what you've learned, might you say in terms of what we should be doing in the UK? Maybe on the modeling side as well as the, the mitigation side. Michael, shall I start with you to see if you've got any thoughts and then hand over to James?
Yeah, I think one of the key things is that you always have to remember that you're always behind the 8 ball with COVID. There's a 5-6 day period perhaps from transmission event to detection. And so one of the things that catches a lot of people off guard, I think, including people here, is that you do something and then you've got to wait 12 days to find out what happens. So if you're going to make a change, make it a little bit earlier. In terms of what needs to be done to keep it suppressed, I think New South Wales has done a great job of what we would normally term a suppression strategy, this rapid track and trace followed by good community engagement that's meant that the people affected have stopped moving and spreading rather than having to revert to the broad brush approaches that we've had to take here in Victoria.
James?
I think it's really hard. I mean, I still don't think we have really good evidence about specific measures. I think contact tracing and strategies, they're really fast. They can be actually more effective than I would say current models suggest, but it's a real race, and you've got to be really fast. I don't think our experience is that schools haven't greatly affected transmission, but I would see universities, on the other hand, as being quite high risk. And so I think that's an area to watch, possibly the end of high school, but then that's difficult because the end of high school is so important from a kind of a educational point of view. And masks is something we don't have good empiric evidence about the actual population level effect. Melbourne, they introduced them, mandatory mask wearing, about 2 weeks before they switched from their phase 3 to their phase 4 lockdown. And if you look at their reproduction number trajectory, it's just kind of a continuous decline. So you can't sort of pull out a distinct effect of them. I don't think it has a huge impact population-wise. I think it's more on the 10 to 20%, but maybe that's a little bit about where people wear them.
Yeah. What would you recommend for universities then, James, just as we're going back here in the UK, just in terms of broad approaches?
So I ought to know better because my school's been involved in the plans here, but I haven't sort of referred to them. I think the concerns are this sort of mix between home and kind of work sort of mixing, in the sense that students often live in groups, they associate in groups, but then they mix in different groups at the university. So it's probably more the home and gathering sort of settings which expand risk, but then there's the possibility for switching of cases across different groups at the university, and of course transmission to more vulnerable people.
Great, and just final question on the modelling. So Cameron South asks, what parameters involved in COVID modelling is used now, especially for the determination of R versus what was being used in the past? So how have you improved that? And are there any other innovative options that you're looking at broadly moving forward? Just final question to you both.
So I think we're fairly sure that R is influenced quite strongly by, I guess, gatherings and so on like that. And we've got proxy measures of that through mobility and through surveys, but they're not, what we lack, I guess, is sort of precise geographically targeted things. And that's a little bit of a challenge. Also understanding sort of household risks. In terms of innovative things, I guess we are looking if you can get more out of the mobility data by sort of other characteristics and so on to see whether this could help to facilitate policies, for example, around regions at more risk. If you had to lock down again, that wouldn't work. And I think that's an area of interest.
Any final thoughts from you, Michael?
Yeah, I guess if I had to pick out one thing that's changed, I think it's probably severity. And early estimates, I think, of severity were based on a detection probability that wasn't as high as we seem to have in Australia. Probably fair to say that we're comfortably above 90%, probably above 95% of detection of cases. And so our estimates of severity have subsequently decreased because we're identifying more of the mild cases. Everything constantly changes in COVID. It's only been around 9 months. We'd still change things for flu, and we've had that for a much, much longer time. Innovative approaches, we're always trying to think of the next thing to model, and like James was talking about before, more accurate modeling of contact structures in particular, thinking about universities, or even mixing of households at sports events or other things like that. That's forever on our radar of modeling based improvements.
Great, thank you very much. That's super. Okay, if the two speakers could just stay on the line for a moment, and I'm just going to introduce the next 2 weeks of webinars, but thank you very much to both of you. That was really excellent. And again, there were a few questions we didn't get through, but I think we covered most things. So our next webinar is going back to a theme we've covered before, of the intersection between communicable and non-communicable disease responses. So we'll be looking at the role of physical activity in prevention and recovery from COVID-19, and also the measures introduced to address the pandemic, what impact that's had on physical activity. Many of you will know Professor Nanette Mutri, and she's joined by 2 expert colleagues. So that will be, 3 expert colleagues. That will be on the 24th of September at 10 a.m. So please do join us. And those of you working in the area or more broadly, please do disseminate that opportunity to your networks. And then I'm really pleased that on Thursday, the 8th of October, we have Dr. Kari Stephenson, who's from Decode Genetics. They've done a very impressive study published in the New England Journal of Medicine, looking at a sample of 10% of Iceland's population, and the findings there about antibodies, infection, and more broadly. And of course, Iceland has a number of innovative features, airport testing, other things I'm sure we want to hear about from Kari. So please do join us then on Thursday, the 8th of October at 2 p.m. So thank you very much to all of you who joined via Zoom. And I know we have a lot of additional people listening on YouTube. Thanks again. Thank you sincerely to our 2 speakers, to the Usher Comms team for their support in the webinar series, and do join us again on the 24th of September. Thanks.